experience that make the whole world smile. By your kindness and talent, and sharing your commitment to help the whole world smile. By your passion and intention, sharing your experience that make the whole world smile. By your kindness and talent, and sharing your commitment to help the whole world smile. By your passion and intention, sharing your experience that make the whole world smile. By your kindness and talent, and sharing your commitment to help the whole world smile. By your passion and intention, lend us a hand. By your passion and intention, lend us a hand. Come to join with us, ICD, give us your hands.
The International College of Dentists is the oldest and largest international honour society for dentists in the world. Established in 1928, the college has more than 12,000 members in 122 countries who've been awarded the prestigious title of Fellow in the ICD. Our motto is, recognising service and the opportunity to serve. ICD aims to achieve 5 goals following the 5 college core values to which they're linked: leadership, recognition, humanitarianism, education, and professional relations. Leadership: to uphold the highest standard of professional competence and personal ethics. Recognition: to recognise distinguished service to the profession and the public worldwide. Humanitarianism: to foster measures for the prevention and treatment of oral disease by encouraging and supporting humanitarian projects. Education: to contribute to the advancement of the profession of dentistry by offering the growth and diffusion of dental knowledge worldwide. Professional relations: provide a universal forum for the cultivation of cordial relations within the profession and to assist in preserving the highest perception of the profession. The Office of the International Council is the world headquarters for the ICD, located in Flint, Michigan, USA. The Council office conducts the daily business and affairs of the college and is representative of the International Council. The International Council is ICD's signature institution and umbrella organisation for the worldwide membership and sections. There are 40 members of the Council, including the international officers and councillors who represent ICD's sections and regions in 122 countries around the world. ICD constitutes 15 autonomous sections to facilitate administration at local and regional levels and to promote more effectively the aims and objectives of the college. There are currently 11 regions within Section 20 Asia sector that cover 16 countries. The number of countries under Section 20 Asia sector is expanding, and we've significantly grown in the number of new members over the past year. In Section 20 Asia, there are 7 categories of membership with different requirements for each of the categories. Emeritus Fellow, Master Fellow with outstanding contribution, Master Fellow, Honorary Fellow with outstanding contribution, Honorary Fellow, Fellow with outstanding contribution, Fellow, for a member with at least 5 years clinical experience who has delivered significant contribution. Honorary Member, Member or Elite who has served the ICD with distinction. Member, or Registered
Good evening, Prof. Ashad.
Good evening.
How are you?
Oh, fine. Alhamdulillah.
Okay, we'll be starting in a short while.
Yeah.
We got about 100, close to 200 that registered for tonight's meeting.
Thank you. I see how much they have the time to attend.
Okay, we got another about 2 or 3 minutes.
Yeah.
Meanwhile, you want to put up your...
Yeah, can I share the slide now?
Yeah, go ahead.
Okay. When you will allow me, then I will do.
Recording in progress.
Yes, Assalamualaikum and a very good evening. Welcome to our webinar, our ICD Section 15 bi-monthly webinar. And today we are in the last month of December, and the first speaker for this month is none other our esteemed Vice President of the college. He is Professor Dr. Arshad Malik. Professor Arshad Malik is currently the principal HBS Dental College, Islamabad, Pakistan. He was the ex-principal and head of dental section of oral and maxillofacial surgery at Punjab Medical College in Faisalabad, and a professor, a postgraduate guide supervisor, examiner, and also paper setter for College of Physicians and Surgeons of Pakistan, University of Health Science, Punjab, Chandrahara University, PIMS, Islamabad, SZAB, how do you pronounce that, University of Bolan, Ishraq University, and University of Lahore. So all the fellows, quite a number of universities he has been attached with. Professor Arshad Malik is the Regent and also Fellow of International College of Dentists at Section 24, Region 24, that is Afghanistan and Pakistan. And Professor Arshad, he is also the President Emeritus of the Pakistan Society of Oral and Maxillofacial Pathology. He is also the President of Pakistan Dental Association, Chakwal, Pakistan Medical Chakwal, and also Fellow of Pierre Fauchard Academy, International Association of Oral and Maxillofacial Surgery, Pakistan Society of Oral and Maxillofacial Pathology. this evening, or might be evening in the Pakistan, but night in Malaysia or in the East. Professor Arshad Malik will talk about inferior alveolar neurectomy as an option in the management of trigeminal neuralgia. Professor Arshad, the floor is yours.
Thank you. Bismillahirrahmanirrahim. Thank you, Professor Ibrahim Dato. It is wonderful with you that you are a maxillofacial surgeon, and it is very promising that the topic today is really a topic I have chosen. It is entirely a very selected topic. We have the wide range of oral surgery, and we have the multiple, procedure which we are doing. But this procedure which I have taken today is a very rarely people used to do. And sometime we used to go for the very aggressive procedures as compared to that of inferior alveolar nerve sacrification. That is my HBS Dental College. These days I am dean there, and as you have described that I am vice president and region in ICT section 15. There are few opportunity which I hold here, and that is related to my different federation, and I am thankful to all these federations that they have made me certain opportunities. Ladies and gentlemen, today which we are talking, that is the inferior alveolar neurectomy, and that is especially for the management of trigeminal neuralgia, a very vast subject. When we are talking of the trigeminal neuralgia, right, starting from the medication, then going for the different injectable therapies, then going for procedures, right, starting from the peripheral neurectomy, going up to the cranium. And in the cranium, there are multiple procedures which today we are performing, right from the Cosca knife, gamma knife, right, Janeta's procedures, and balloon interference. There's a wide range of treatment we have. But this inferior alveolar neurectomy is the treatment which is limited to a local level. Say a person is sitting in the rural area and he has the experience of neurectomy. The patient is fed up of giving medicine to the patient, anticonvulsant. The results come, then patient says, the doctor, I'm fed up of medication. Or he say that these side effects has appeared in my body after taking these medication. So what to do? At that level, sometime we should start to giving injectable therapy. And that injectable therapy may be in the form of alcohol, glass rolls, in the form of even nowadays botulinum toxin. And these all, whatever we used to give, a stage come, patient is also fed up of these injectable therapies. And sometimes we are in favor to go ahead for a surgical procedure, which should be having a minimum invasive technique. Having said that, I'm going to conclude in this half an hour, 45 minutes, these parameters. When we look at the historical background of inferior alveolar neurectomy, I was tracing whole the history, and I found this overview by Betel. He has given a detailed description of the history of trigeminal neuralgia, where he evaluated the neurectomies, especially in a vast subject. And from here, we come to know that the neurectomy actually is the procedure which started just 100 years back. And this 100 years back neurectomy procedure really given a very much satisfaction to oral and maxillofacial surgeons for uh, just giving satisfaction to the patient's outcome. When we see in the initial stages, approximately 3000 BC, we see on the temples of Egypt, there are different carvings and photographs which shows that these procedures within the mouth, it started at 3000 BC. But when we come to the trigeminal nerve, it is the first time in 16th century when Fallopius described the anatomy of the fifth cranial nerve. And that cranial nerve that he described, he missed so many branches at that time. And later on, when we see that there are many branches with the Fallopius in the initial stages, he missed. When we start the procedure of neurectomy, that is the Dandy first time in 1934, he given the intraoral approach for the inferior alveolar neurectomy. That was a wonderful approach. But the limitation is that he has described it in such a vague way that precisely the location of the inferior alveolar nerve in his study and in his research was not demarcated for the coming pupil. What happened? That because he was basically a neurosurgeon, but he has gone intraorally, and his approach worked for a very long period. Then in Ronald, 1951 described the extraoral approach for the inferior alveolar neurectomy. And this approach was very promising, and especially for the general surgeon and for the neurosurgeon, because they know the anatomy outside the oral cavity more precisely as compared to that of the intraoral. So what happens that this procedure become slowly famous, and people started inferior alveolar neurectomy by extraoral approach. GINWALLA from India was the man who really described the modified approach of the inferior alveolar neurectomy by intraoral way. He described it in such a wonderful way that he started the incision from the coronoid process, coming down, making it Y-shaped, and dividing the two half of the medial and lateral side into two ways, and then visualization of the medial pterygoid muscle and visualization of the temporalis muscle was very nicely done. This is now very famous, and it is a very promising technique as well, better than what you say Dandy. QUNN'S describe an intraoral approach, but by a lateral way. What he does, that he used to have the cut on the lateral side of the mandible, which I will describe you later, and he just exposed the nerve, and here he go for the neurectomy. Ladies and gentlemen, in 1981, the people, after their previous so many years experience, started evaluating the inferior alveolar neurectomy procedure results. Approximately in the literature, 632 papers was written about the inferior alveolar neurectomy. And I have selected few papers which has remarkable impact on the general public, and especially the public who is dealing with the neuralgia, whether they are general practitioner, whether they are a neurosurgeon, or whether they are oral and maxillofacial surgeon. Fremont actually concluded in his 146 patient that the peripheral neurectomy is a useful and simple method of pain control in trigeminal neuralgia. Later on, in 2008, a very good paper was published by Syed Amjad Shah. I'm proud of this man that he's from Pakistan, he's from KPK, and this man has written such a wonderful paper, and very genuinely he gave the analysis. He said that this branch, when you go for the neurectomy, there is a association of reoccurrence and there is the loss of sensation, but it is very useful for the elderly patient having limited lifespan. This Amjad Shah and have done a very marvelous job for evaluating the inferior alveolar neurectomy. Then 2011, the 30 patients were evaluated by the Agarwal, and he said that this is a minimal invasive form of surgery and well tolerated by the patient, but he has performed this all surgery in local anesthesia. Then in approximately 2012, a peripheral neurectomy is safe and effective procedure for the elderly patient. This was the Ali FM. He said that it is absolutely a safe procedure, and he given many clear-cut indication for this. Then in 2016, a patient was done by the gentleman Patel, and he said that patient has very nicely tolerated and cured the peripheral neurectomy, and he has done this procedures by the GINWALLA approach. In 2017, another case was done by Malady, and he said that no reoccurrence I have seen in 3 years of period. Another paper in 2020, a very interesting paper, that is histological evaluation. And this histological evaluation resulted into a vision for the maxillofacial surgeon that what is the effect of inferior alveolar neurovascular bundle on the trigeminal neuralgia. And they said there's the demyelination of inferior alveolar nerve due to pathological vascular changes in the peripheral vascular may be the role of initiation and participation of trigeminal neuralgia. It's a very interesting research. And he said, hence the peripheral neurectomy has a significant role in alleviating the pain. Recently, in this May, a very nice publication done by Professor Nagy, and he said that the peripheral neurectomy provide short to medium-term pain control of the trigeminal neuralgia. And he also said that due to this neurectomy, you get the very good relief of the anxiety, pain, and depression as well. Reaching right from 3000 BC up to 2021, this whole historical background reaching to the trigeminal nerve pain and coming to the inferior alveolar neurectomy. Ladies and gentlemen, this is a task that we are going to have one option, that is the inferior alveolar neurectomy, and that should be done by a very safe hands and very the expert hands. For that purpose, if you see what is the indication, after getting the historical background, the indication going to that, first see what is the trigeminal neuralgia diagnostic criteria. You have to see this criteria of the suite, that pain is proximal, the pain may be provoked by light touch on the face, confined to the trigeminal distribution, pain on the unilateral side, and the clinical sensory examination is normal. There's no any sensational loss. Ladies and gentlemen, after having clear-cut evaluation, you are going to have the indication of inferior alveolar neurectomy. We have three only inferior alveolar neurectomy indication. What is that? Is the trigeminal neuralgia involving inferior alveolar nerve. That is the first thing, that when there is no medication, when there is no any other thing is effective, then you are going to have this inferior alveolar neurectomy. Painful invasive malignancy of the mandible, when you have no any clue, you can go ahead for the ID neurectomy. And long-standing herpes zoster pain in the lower jaw area, and that is these are the three mainly indication of inferior alveolar neurectomy. Now, what is the contraindication? The contraindication of inferior alveolar neurectomy are medically unfit patient. Obviously, whatever the condition, painful condition may be, the surgical fitness of the patient is mandatory. Below the age of 18 years, because if you get the radiograph, you see the inferior alveolar nerve is in the vicinities of the periapical areas before the 18 years. As the maturity comes, the teeth move up from the cortex of the inferior alveolar nerve, and there is a space where you can go ahead for the neurectomy. Secondly, the impacted molar, they generally lies within the vicinity of inferior alveolar nerve. So you cannot have the proper enucleation of the inferior alveolar nerve. When the medical treatment is effective, obviously you are cutting an organ, you are giving a permanent anesthesia, paresthesia of the area. And secondly, you are not going to have the regeneration or coming back of this nerve again. So it's a very drastic methodology. So before going for this methodology, you rest assured that you have to be very precise, that if other methodologies are effective, do not go. Like cryosurgery treatment, because here just the pain is over, but there is no any loss of sensation. And when soft laser therapy is effective, then you are going to have this inferior alveolar neurectomy not to be done. This is another study which was in 1990, and they said that after removing the inferior alveolar neurovascular structure, no effect on the mandibular growth, but delayed in the eruption of the permanent dentition. Due to this study, we don't want to go ahead for the removal of inferior alveolar nerve before the age of 18 years, because we want the eruption of the impacted teeth or wisdom molars into its proper occlusion, and then we are going to have any procedure. This is one of the contraindications you see, that this is the below the age of 18 years. The young person, there's all the permanent buddings, they are present there, and you are not able to get the absolutely enucleation of the nerve. Then that is the X-ray evaluation of impacted teeth roots in the ID canal. Here you can go ahead for other procedure, but it is very difficult to enucleate the whole of the inferior alveolar nerve in this type of background. The laser therapy or soft laser therapy, it is the talk of the town now, and it gives response to the trigeminal neuralgia patient. And these are so many studies they are present that this laser therapy on the trigger zone or in the hot spots give very promising result. And other thing, that is the cryosurgery when it is effective. In Pakistan, there are so many publications. One publication is by Professor Riaz Walais, that he has performed the cryosurgery on the nerve, and that is one of the very important thing. He said that there's no loss of the sensation, but there is relief of the pain. Ladies and gentlemen, we are going to have a inferior alveolar neurectomy, and for that purpose, we are going to have the surgical anatomy. You can see the surgical anatomy of inferior alveolar nerve. That is the inferior alveolar nerve coming, and that is right from going to here, sphenomandibular ligament, pterygoid and mandibular canal, and that is the inferior. These are the branches. They are myeloid nerve. That is the inferior alveolar nerve going into the canal, and that is the inferior alveolar sphenomandibular ligament, myeloid artery separately there, and inferior alveolar artery going within the canal. And this emerged from the mental foramen after giving supply to the all teeth, and this mental nerve emerged from the mental foramen and supply to the skin mucous membrane of the oral cavity, as well as to the anterior incisor teeth. After having the concept of this ABC of the inferior alveolar nerve anatomy, you see these are the important structure. That is the vicinity where you are going to perform the inferior alveolar nerve. This is the masseter muscle. Here is the medial pterygoid muscle, and above is the temporalis muscle. This is the area where the lateral pterygoid muscle is placed, and we have the masseteric space here, and we have the pterygoid space here, and this space we are going to operate right there. And if you are sharp enough, you can separate the temporalis and medial pterygoid, and slightly you can elevate the masseter muscle and you can reach there. That is the anatomy generally we used to face this surrounding in old age, and the foramina come above. And this old age in inferior alveolar neurectomy, generally the path which is used to we see, it is the above level, and it is right coming from the lingula. That is the path which we used to see. So the inferior alveolar neurectomy in old age become easy. Now that is a space on the lateral aspect of the ramus. This you see we can make a window, and this window we can enter inside. You will rightly facing the lingula from the inner side. So from outside the ramus, if you enter right from here, you are going to face the inferior alveolar nerve entry from the medial side, and then coming to the mental foramen. The another space is that is this external oblique ledge, big shelf. If you going to cut this shelf and you remove this shelf, you are going to face the inferior alveolar nerve right coming in this area and then coming to the lingula. So for the neurectomy in the intraosseous way, you can go for these two things. And third is the routine way. That is the what the GINWALLA have done. He started right here from and getting the Y shape incision right here and separating the medial side and the lateral side and going straight back and elevating the inferior alveolar nerve. No, ladies and gentlemen, these are the just an introduction for the inferior alveolar nerve, its indication and its anatomy, its contraindication. Now we are coming to the main topic, that is the surgical procedure. In surgical procedures of inferior alveolar neurectomy, we have three procedures. Two procedures are intraoral procedure. One is the extraoral procedure. The intraoral procedure, one is the GINWALLA, and that is from the India. This GINWALLA procedure actually is a modified procedure from the Dandies. Dandies has introduced an intraoral way of approaching to the inferior alveolar nerve in 1934, but the GINWALLA has modified it in 1961, and now it is a very famous procedure. When we are going to have the inferior alveolar neurectomy, first we perform the mental neurectomy. After elevating the mucosa in the 4-5 area, we are going to see the inferior alveolar mental nerve right there. And after exposing it, we see the mental foramina and we expose it. And just retracting the mucoperiosteum back. And by the curved clip, you just hold it and hold it firmly. You can retract it back and you can cut it as well. So this is just a description of the mental neurectomy, which is mandatory for every procedure of the inferior alveolar neurectomy. We perform first the mental neurectomy, and then we are going to proceed the other methods. Now, first the procedure for the inferior alveolar neurectomy, which I am going to describe, is GINWALLA. The GINWALLA procedure is that longitudinal inverted Y-shaped oral incision in between the external and internal obliques. After dissecting the temporalis and medial pterygoid muscle approach to the lingual by blunt dissection, separate the nerve from the sphenomandibular ligament, which is attached to the linguala of the mandible. And when you separate it, it is very nicely clear. Avulsion of the nerve from the canal after mental neurectomy that you have done in initial stages. Now I showed you the case. That is the lady. Approximately she's 60 years, and she reported to Laser D Dental Clinic for she been on the medication, but now she is fed up of medication and she requested for the inferior alveolar neurectomy. That is the mental neurectomy we perform. It is your good will that whether you after mental neurectomy you give the stitch straight forward or you give the stitch after ID neurectomy. This is your good will. After mental neurectomy, you give the reverse Y incision separating. This is the medial side, this is the lateral side, that is tongue, and right coming from here you can have the inverted Y GINWALLA incision. Now after the incision you move forward, and that is the lateral side, that is the medial side, that is the mandible which you are looking at, and you are entering right posteriorly. You place your one blade at the superior level of the Haworth, or you can die, and then the second blade you can place it beneath the lingual level, like we used to perform in the sagittal osteotomy. And then you see the lingula right there. That is the lingula, and that is the nerve right there. You can see the nerve, and this is the you have separated the temporalis fibers. Few fibers are here, and this is the dissection of the medial pterygoid, and that is the lingula, and that posterior side, that is the inferior alveolar nerve. And hence, when you separate it, that is the exact emergence of the inferior alveolar nerve right there. And then you remove it from the inferior alveolar canal by pushing it from the back, and you remove whole of the nerve from the ID canal. And after removing from the ID canal, you are going to have the stitch on the posterior aspect, and here you stitch it, and then after stitching you cut it. And after cutting, few people these days favor that you go for the cauterization of the nerve as well. After cutting, you are going to have the stitches. These are the stitches right of the GINWALLA's incision, and that is the mental neurectomy incision. Ladies and gentlemen, if you just go for the advantage is there is no bone cutting. Intraoral oral approach, so there is no facial scar. And there is less chances of regeneration of the nerve because you have removed it right from the canal and total removal from the posterior side. When we talk of the disadvantages of the GINWALLA's technique, chances of damage to the pterygomandibular ref, it is sometimes possible, but generally the expert surgeon do not have this problem. Difficult approach due to improper vision because you are working in a very dark posterior aspect. But there are so many lightning resources are there, but yet there is lack of visibility due to the oral cavity because only the lip has a limitation of the opening of the oral cavity. Then is the most facial spaces are open to infection, especially the pterygoid space, lateral pharyngeal space, deep temporal space. They are actually in the vicinity and they generally used to open. Cannot be performed in restricted mode of obviously in the restricted move like you see submucous fibrosis are infected, or even in the microsomia you cannot do it, even in the microgenetia you cannot do it, even in the macroglossia it is become very difficult because tongue is very big. So these are the certain difficulty index in which the inferior alveolar neurectomy in the oral cavity is very difficult for, especially when you are performing the GINWALLA's approach. Chances of damage to the lingual and mylohyoid nerve, which is actually sometimes become part and parcel, because when you remove the nerve from linguala, you generally used to damage the mylohyoid nerve. Now we are coming to the second procedure, and that is the QUEEN procedure. QUEEN procedure actually, he is saying that we are not going to back so much, just we go to the lateral external oblique ridge on the lateral side. You make a window 0.5 to 1 centimeter below that gingiva, a rectangular entry of the 0.5 to 1.5 at the lower border of the anterior aspect of the ramus. You can go ahead for this just at the external oblique ends, and the coronoid process starts you just at that level where these two are joining. You can make a rectangular window. Expose and reverse the nerve after mental neurectomy and pack the bone chips or bone wax in the bony defect. How you are going to do this is what you say that you are going to have this incision. In this incision, you can have the dual aspect. You can do mental neurectomy as well. After that, you are going to have the window formation, and here you get the avulsion of the nerve, and then you pack it, and these are the stitches. And that is my case by the QUEEN. That is the patient, and we are going to have the as an incision on the lateral side like this, and we are going to expose the bone. Now that is the lateral. This is the incision, and that the lateral aspect we have exposed the bone, and after exposing the bone, we are going to have making the window. This window is being made by bar, Fisher bar, and after removing the bone surface, you are going to expose the inferior alveolar nerve. That is the inferior alveolar nerve right there. And after exposing the nerve, you are going to remove the nerve right from the mental foramina up to this level, and you can have the remedy of the nerve. And then after that, you can pack it by any artificial bone or bone wax, and then you are going to have the stitches. This is what do you say? But these days, modern days, we have the very good piezo surgery, and we are going to have the formation of the window by a very delicate way. You go for the cutting of a lateral aspect of the lateral border, and then you slightly push the area of the rectangular piece. This is a wonderful way that you are not going to lose the bone, but you are going to have the safety of the bone which you have removed. You can replace it back after neurectomy. After cutting the bone, you remove this whole rectangular portion, and you after that you see that is the nerve right there. And after uh, uh, doing it, you can remove the enucleate the nerve from the bed, and you can do the neurectomy. And after that, you can pack the that piece of the bone back. What are the advantages of this QUNN'S approach? That is, less facial spaces are involved. It is intraoral approach, no facial scar, no damage to lingual or mylohyoid nerve, better vision of surgical exposed area. These are all the advantages. The advantages which those are the disadvantages of the GINWALLA's approach. These are QUNN'S covers all these disadvantages of the GINWALLA. So disadvantages are more chances of the regeneration. The procedure which we are doing, actually we are not removing the nerve right from the lingula. We are removing it from the body, and maximum we can retract it is a limit. And when we pack it, there are chances that in that empty space, there may be development of the neuroma, and there may be chances of regeneration. Cannot be performed in the deeply impacted third molar, because if the molar is there, then the performance of QUNN'S approach is not there. Bony defect may result into traumatic bone cavity, and that is one of the misery that you can find, that there is no healing done after the QUNN'S approach, and you can see after 6 months the empty space, and that is idiopathic bone cavity. Ladies and gentlemen, now we are coming to the last procedure. And this last procedure is a very interesting procedure, and it is generally favored by the general surgeon and neurosurgeon, because they are very afraid in the oral cavity, and they are very brave outside the oral cavity. The extraoral inferior alveolar procedure, a submandibular incision or a crease incision you can give in 1 inch to 1.5 inch antegonal region, and approximately midway between the last molar and the angle. On the outer side of the face, you can evaluate that there is the angle of the jaw, and that is the last molar. And from here, you divide the area, and you come to know that that is the midway. Platysma and masseter muscle fibers are separated, and periosteum is elevated. 0.5 to 1 centimeter bone window is formed. Expose the nerve and avulse after mental neurectomy, and pack it with the bone wax, and the bony defect is being covered. That is the important thing, that is a facial artery, facial vein, then there is a 7th cranial nerve, retromandibular vein, and these all area. That is the only safe way you have to go for, or you going for the deep range. That is very important thing when we are going to perform the extraoral inferior alveolar neurectomy. These are the two incisions which are generally favored. Either you go for the resident, modified resident, or you go into crease, and then after exposing, that is the path where the nerve is leaving the lingula. This is the opposite side of the on the lateral side of the bone, and on the medial side, that is the lingula area. And from here, you go for the neurectomy. That is the incision. Then you separate the platysma, and after cutting the platysma, you separate pterygomandibular F, you save the nerve, and then you are going to have the ligation of the vessels, You make the window right there on the lateral aspect of the ramus, and then you are going to avulse the nerve and going to have the stitches of the area. That is my case. That is a young lady, and she preferred that for the inferior alveolar neurectomy, and this we have performed there, and that is the incision we have given, and just it is elevated. It is slightly low incision. I have just elevated by my fingers to show you, and then just exposing the platysma, and after cutting off the platysma, then we're cutting the masseter muscle and exposing the lateral border of the ramus. And here we have drilled the lateral side of the ramus, and after getting the window, you just see that there is the presence of the inferior alveolar nerve right there. You, by the fine hook, you just elevate the nerve. As you have done mental neurectomy, you retract it as that the whole nerve is right coming from this area, that is mandibular area. You have removed all of the nerve right here, and after getting, you push the cut nerve towards the linguala side, and after area on the medial side, you stitch it, and then you pack the area nicely sterile area, pack it with the bone wax or spangistan and whatever you have, and you are going to have the stitch. And generally, what we perform here, it is that we used to have the electrocautery with you, and just I make the videos fast so that you can have the less time. I make it fast like this. Yes, you see, yes. After elevating the, yes, you see the masseter muscle, and we are exposing the bone, and that you see. That is the procedure which I have already described. It is just a practical, just you see the how we are performing it on the lateral aspect. That is the same procedure which we have. The advantage is there's no damage to the lingual nerve. Obviously, you are on the outer border. Less chances of regeneration because you remove all of the nerve right from up to lingual level. Less facial spaces are involved. Just you are working on the masseteric space. Better vision of the surgical exposed area because just it is in front of you, and less chances of post-operative infection. And that is all the disadvantages which we have in QUNN'S approach. The extraoral approach become overcoming all these things. Now, what is the disadvantages? Number one is extraoral scar. Number two is the bony cutting procedure. You may have the idiopathic bone cavity. Damage to the great auricular nerve, you may have going to damage the cervical branches of the facial nerve or great auricular nerve. These are the disadvantages. Ladies and gentlemen, what is my conclusion? The conclusion is that during my study, which was just at the Laser D Chakwal in the previous year, we have 19 inferior alveolar neurectomies, 8 lingual, 6 buccal, 34 mental, 30 infraorbital, and 1 supraorbital. These all are cases referred to me by as a all of maximum, you know, I have worked whole my life to the trigeminal neuralgia, so the cases maximum they are referred to me, and I at a low level I choose the inferior alveolar neurectomy. In all these cases which we have performed, I have maximum performed 12 cases in GINWALLA. This GINWALLA approach to me for an oral surgeon is easy. For me, it is an intraoral approach. For me, you can perform it as local anesthesia. For me, you have a more orientation of the anatomy as a or a surgeon as compared to that of the extraoral. But I think that these three are the important methods. It is entirely depend upon the feasibility of the person that who can perform which type of neurectomy. But it is one of the excellent procedure that it is a safe one. It can be performed at local anesthesia, and obviously experience and guide supervision of the initial stages. It is mandatory. Ladies and gentlemen, thank you very much. We generally used to have the trigeminal neuralgia day, and that is 7th October. And this is being celebrated throughout the world. And 7th October is the Trigeminal Neuralgia Day. Ladies and gentlemen, thank you very much for patience listening and attending this seminar. It was especially for the general practitioner, postgraduate student, and especially for the final year student as well, who are going to have the trigeminal. Thank you very much.
Thank you very much, Professor.
It is over to Professor Ibrahim.
Right. Thank you very much, Professor Malik, for the very detailed, informative presentation about the, and also you have touched the surgical at the beginning of your lecture. You have touched about the background and then the anatomy and so on, and very informative. In fact, as you have said, for the undergraduate student, if you are here, it would be useful. But I want just now we have a few questions from Shah Malik. That the first one from Anonymous in the Q&A said, if clinically the trigger zone is only present on the area of distribution of mental nerve, would it suffice to just to snip off the mental nerve at the level of the mental foramen instead of performing a full inferior alveolar neurectomy?
Yes, I prefer mental neurectomy.
Sorry?
I will prefer mental neurectomy. I will not go for the inferior alveolar neurectomy because the trigger zone is if limited to mental area only, that I don't want, that I should be more aggressive. Better to perform mental neurectomy in the initial stages, and if it fails, then you are going to have the ID neurectomy.
Okay, all right. I think our president also has joined you tonight, Dr. Howie, so with us this evening, from Sajid Malik. Then the other question from Professor Mutiur Rahman is that what is your experience about the recurrent pain after neurectomy? And that's the first question. And the second question is, why did you prefer external approach for the young lady?
That is really a very this question has been asked to so many platforms when I present this case, that why I perform the neurectomy outside. Actually, this is the especially with the consent of the patient, and I requested that there are 3 procedures. 2 are intraoral, 1 is outside. Which procedure you prefer? You want outside? She said, don't touch my mouth inside. I don't want to cut my mouth. I will prefer that if you have the chance of doing it from the outside. I don't matter for the extraoral scar, but I don't prefer that you should cut my mouth. So that was the reason that we gone from the outside. And secondly, reoccurrence in QUNN'S approach is more. The cases which I have done, 5 cases I have reported in my study. These 5 cases, approximately, I can say 3 cases they reported me back. And this is the reoccurrence by the QUNN'S approach. And this reoccurrence is generally after 6 months you can expect from the QUNN'S approach. But the GINWALLA approach and the extraoral approach, I don't think that extraoral approach, because I used to do very less. It is only the person who has limited mouth opening and cannot let me to work freely in the retromandibular area, then I used to go for the extraoral one. And that's why we used to perform the extraoral. Intraoral, the QUNN'S approach, which I have made the window on the lateral aspect of external oblique ridge. This lateral window approach, actually, we remove the nerve, some portion of the nerve right from the lingula to the defect. It remains inside. You cannot remove it. And that left portion used to regenerate. Otherwise, in GINWALLA's approach and in approach of the extraoral, there's very less chances of regeneration.
Okay, all right. Thank you. I don't know whether you answered the first part. What is the experience about recurrent pain after neurectomy? Recurrent pain after neurectomy.
Actually, you have to understand the trigeminal neuralgia. Trigeminal neuralgia is it is the pathologic is associated with that particular nerve which you are sacrificing, then you remove the trigger point. But you know the Janitas procedure, if it is in the brain and the target is the especially I will say internal carotid artery, if it is making a symphon around the any ganglion portion, so you cannot get the assurance that whether after removing your this nerve you are going to get the relief. So after this nerve you may have the trigger zone of any other part of the Gasserian ganglion, and you can have the pain by another branch, that may be buccal nerve, that may be lingual nerve, and you can find the trigger again.
Okay, all right, thank you, Professor. And another question for our Q&A is that may I know why does QUNN'S procedure have a higher chances of nerve regeneration compared to the extraoral?
Because in QUNN'S procedure, lateral window is open, and you can remove right from the mental foramina up to the end of the window. You cannot reach to the lingula by this approach. So the portion of the posterior portion remain in the bone, and the regeneration occurs generally. That's why the QUNN'S approach is very less performed.
Okay, right, thank you. And we have one question from the chat box. How about neuropathies in the long buccal nerve? Will neurectomy of the inferior alveolar nerve address this?
Pardon, I don't understand.
They said, how about neuropathies in the long buccal nerve? Will the neurectomy of the inferior alveolar nerve address this neuropathy?
No, not at all. When you see the anatomy of the foramen ovale, it directly divides into two separate divisions. One is called anterior division and second is called posterior division. The anterior division has only one nerve, and that is buccal nerve. And posterior division has the four nerves, and that is lingual nerve, that is inferior alveolar nerve, that is nerve to mylohyoid, and that is auriculotemporal nerve. These four branches are from the posterior trunk, and the anterior trunk emerge separately, and it do not have any interference with the inferior alveolar nerve pathway or orientation.
Hello?
More up to the level of coronoid process, or immediately you are going beyond the limit of the lingula, then you may damage the inferior alveolar nerve, buccal nerve. Otherwise, there is no possibility.
Okay, thank you, Professor Malik. We have another question from the Q&A. The question is, have you seen any patient with isolated lingual neuralgia? And for such cases, if medical treatment did not work, are there any surgical treatment? Do you get the question?
Isolated trigeminal neuralgia is the pardon?
Sorry, do you mean to repeat the question?
My pardon, Datu?
Yeah. Have you seen any patients with isolated lingual neuralgia? In such cases, if medical treatment did not work, are there any surgical treatment?
Yes, you can go to brain. You can go to have the Janeta's procedure. You can go for the intracranial procedure. This peripheral neurectomy, it only the limited to the ID canal and ID nerve, and that is the what you are going to have.
Okay. All right. Another question we have from Romisa Zafar. He said, which is easy of all the three procedures? Is it GINWALLA? The three procedures, which is the easiest?
Yeah, actually, GINWALLA is preferable for me. I cannot say that it is for everyone. The literature, approximately 22 papers has been published on the base of the GINWALLA's research. And since 1961, the procedure remained very in the initial stages. I used to perform the dandies approach, and one my friend from the India, Datu Hawkam Chan, also know that Balaji. He met me in during conference, and I discussed the same thing. And he said that whether you perform GINWALLA's, I said no, I just performing dandies approach, and he preferred that you go for this procedure. And when I started this GINWALLA's approach, it was really very preferable, and I feel comfortable with GINWALLA's approach as compared to other procedures. It is the modified approach of dandies procedure, actually.
Okay. All right. Thank you. Another question, Professor Arshad, from the Q&A. Of course, it's anonymous. Hope you can share how to do infraorbital neurectomy in future.
Sure. It is all Datu Muhammad Ibrahim and my president Datu Hawkam Chan. They permit me. I am always there to present. These are my favorite topics. Infraorbital neurectomy, no doubt. Whenever you will say, I am there at service.
Okay, I'll take note about that, Professor Arshad. Infraorbital neurectomy, yeah?
Okay.
Okay, we have two more questions, Professor Arshad. May I know your indication to do MRI for trigeminal neuralgia patient? Is there indication for MRI before you do the neurectomy? Or do you need necessarily do MRI?
Yeah, MRI is a wonderful procedure because MRI gives you the evaluation that whether your lesion is intracranial and which part of the vessel it is touching the ganglion, or it is the post-ganglionic problem, or it is a ganglionic problem, or it is whether there is preganglionic fiber. Whether your procedure wanted that this inferior alveolar neurectomy is indicated, and that is what the MRI used to give you a very good clue. Say if the tumor is there, if there is any schwannoma is there, or there is any meningeal problem is there, that will be evaluated by MRI. For my procedure, because it is a bony path, and for the bony path, MRI generally is not so promising as compared to that of CT scan. Now coming of the CBCT, it is more wise as compared to that of MRI for neurectomy purpose only.
Okay, looks like questions still coming for Ashad Malik. The next one is what scan to find out if reason for neuralgia is in cranium?
There are approximately 17-18 lesions, and the most common is sclerosis. That is systemic sclerosis. That is the most commonest one. Then when there is systemic sclerosis, there is generally the trigeminal neuralgia is there. The whole of the brain, it is influenced by this disease, and due to this disease, there is generally the trigeminal. Then other diseases, even the cyst of the meninges, even the hematoma by after trauma, then there is a schwannoma, there is any meningeal growth at the base of the skull, there is any malformation of the bony part of the petrous part of the bone. There are all these problems which are intracranial problems, and main is the systemic sclerosis, which is the most notorious one in trigeminal neuralgia.
Okay, another question from anonymous again. What will be the worst case of scenario of failed neurectomy?
Pardon?
What would be the worst case scenario of a failed neurectomy? Or the side effect?
Patient will report to you with a very bad attitude that you have cut my face, you have cut my mouth, and yet I am there. You can regeneration of the nerve is always not a good sign for the surgeon who is performing. And the main worst thing is the formation of neuroma. And neuroma formation results into the multiple connection of the other branches as well. And that results into severity. That neuroma, or if you get any growth there, and schwannoma you get there, that may become a more problem after neurectomy.
Okay, we have another two questions, Professor Ashad. Is there more recurrence after mental neurectomy? Or
mental neurectomy, yes.
Okay,
mental neurectomy regeneration is there.
Okay, can we go for inferior neurectomy for mental nerve neuralgia?
I don't favor that. It is, if it is only limited to mental nerve, why to sacrifice the inferior alveolar nerve? No, the problem which I want to highlight is that the mental nerve, it actually only supplies to the lip, buccal side, and then to the gingiva, and to some extent the incisive branch also emerge from the inferior from the foramina vicinity as well. So when you are going to sacrifice a nerve, you know, this is not a only nerve, it is a neurovascular bundle. And this vascular bundle contains the sympathetic chain. And this sympathetic chain actually give a very nutritional episode to the muscles and to the skin. When you cut a nerve with a neurovascular bundle, when you cut it, you are going to have the thinning of the muscle, and you will see that side of the lip and that side of the skin become not so healthy or thick as compared to that of where you are getting the supply properly. So when we go beyond to the mental foramen towards the lingula, this is all the intraosseous path, and this intraosseous path gives nutrition and nerve supplies to the teeth. So when we are going to cut the inferior alveolar nerve, Indirectly, we are sacrificing all the neural supply of the teeth, all the vascular supply, direct vascular supply, which gets from the periapical foramina. We get it out. So now the teeth are surviving only on the periodontal diffusion, and you cannot say that what is the future of the pulp. Some people say the pulp after the inferior alveolar neurectomy, all the pulp of the teeth, it become the non-vital. But as it is aseptic condition, you do not get any type of sign and symptom. These nerves become sclerosed. They are become fibrous there, and these teeth sometimes become brittle as well. So why you when the your target is achieved by mental neurectomy, why to go for the cutting of the inferior alveolar nerve? So I will prefer that when the target is mental nerve, do not perform the inferior alveolar nerve. Let the posterior teeth enjoy its nutrition and its nerve supply.
Okay, all right. Thank you. I think we are now down to the last question, Rashad. I guess it's the same question, one in the chat box, one in the Q&A. From Dr. Murshid Alam. So after surgical treatment, is medical treatment required?
Yes. We have seen that after performing the mental neurectomy or ID neurectomy, sometimes people do get the neuralgic attack. The trigger zone you have removed, the sensation from the lip, it is gone, but the target, if it is intracranial, the shooting of the hot spot is right there. And when there is any episode there in the brain, it is going to activate the posterior limit. Say you get the mental nerve, patient will report with the pain on the teeth. When you are going to, you see that so many people, they come then, sir, I just get the pain on my last tooth. Please extract my last tooth. They extract it. Then is seventh start. Oh, so second molar. You remove it, it comes to the 6. You remove it, it comes to the 5. So on and so forth. It move on till the mental nerve. And at whole of the vicinity of the nerve, which is on the trigger, you are going to have the extraction. That's why the use of the carbamazepine or anticonvulsant, Trigeminal or baclofen or whatever you are using, sometimes we require for 1 or 2 months. And after that, when the complete wound is healed, then we don't need these anticonvulsant drugs.
Okay, I told you it was the last question, but actually there is one more question. The question is from Dr. Sana Babar. What to do after recurrence?
Yes, recurrence, it entirely, you have to get the consent of the patient, because recurrence change the attitude of the patient, because it comes with a more threshold and more aggressive as compared to that of primary neurectomy. So you have to get the consent. If the patient permits you, better to reoperate it. When you reoperate, you will see there is neuroma formation, and there is multiple neuroma branches are there, and you remove all of the area and you filtered it. But if the patient do not it is better that you refer this patient to neurosurgeon for your procedure.
Okay. All right. Thank you, Professor Arshad Malik. I think that's about all for the questions. Of course, we have Romeza from Jaffa asking for the recording.
Yes.
Yeah. This is available on our YouTube channel. If you go to ICD section 15 education, it's available, the recordings. So Romeza, you can go there for the in the YouTube channel. Okay, thank you very much, Professor Ashar Malik. So, and it was a very informative lecture, and we hope okay, Dr. Jaswan has raised his hand, our senior fellow. Anyway, Dato, how you got anything to
Yes, sir.
our speaker or vice president, Dato?
I just want to say thank you. I just want to say thank you as usual. Sorry. Yeah, I just want to say thank you as usual. Professor Ashar's lecture is always very impressive and full of question and answer, and it's very interactive. So I want to say thank you again, and I wish everyone Merry Christmas and Happy New Year. All right. And I also want to thank my education committee, especially our chairman, Professor Mat Ibrahim, for organizing a whole year series of education program. And thank you, everyone. Thank you.
Thank you, Dr. Hao. We have another one before Christmas, Dr. Hao. So this is the one. All right. Okay. I just want to share with you before we end this session. I guess Dr. Ashar Malik for the very informative lecture. So, and on behalf of Section 15, we would like to thank you for you to spend more than one precious hour with us, with our participants tonight. And then for next one, as usual, I will announce for next one. We have our speaker. This is again one senior member of a Malaysian professor. She is in fact our fellow, Professor Dr. Rahimah Abdul Qadir. She will be talking about addressing the preventive oral care needs for the graying ASEANs. So this is our topic on the 22nd of December. Hope you can join us again for this public. This is more, we're going in the public health area. This is the second time we had, or third time we have in the almost 2 years series that we will going on. So I hope you will join us to hear our speaker, Professor Dr. Rahimah, on addressing the preventive oral care needs for the graying ASEANs. With that, I think I'd like to thank all of you who have joined us tonight, and hope that all our speakers have been given good input, and hopefully we will see you again in 2 weeks' time, inshallah. And of course, on behalf of Section 15, apart from thanking our speaker, I also like to thank our committee, Dr. Amy, Amelia, and also Associate Professor Datin Dr. Mayuna, who has helped me in organizing this webinar series. Thank you, and see you all tonight in 2 weeks' time, and good night. Thank you.